Welcome, everyone, and good afternoon, distinguished guests. My name is Josephine Tyne. I'm a United Nations representative for Concepts of Truth, Inc., a faith-based NGO that provides mental health resources and an international crisis helpline to promote mental, sexual, and maternal health. We're very honored to have you all here. Thank you very much for coming. And we're particularly grateful to the Permanent Mission of Burundi to the United Nations. So I'm pleased to introduce our panel of experts who are here to address the mental health harms of pediatric gender-affirming care. And we'll begin with His Excellency Zephyrin Menoratanga, the permanent representative of Burundi. Ambassador Menoratanga has received multiple academic degrees, including master's degrees in international relations and international environmental law, a postgraduate degree in international human rights law. His Excellency has taught courses on human rights, on conflict resolution and leadership at the University of Espoir d'Afrique in Bujumbura. He's worked extensively to defend human rights with UN organizations such as UNESCO and the Office of High Commissioner of Human Rights, and published papers on human rights and conflict. In March of 2021, he was appointed ambassador and permanent representative to the United Nations, where he has served as president of numerous committees, including the 2024 meeting of the parties of the Convention on the Rights of the Child. Ambassador Menoratanga will now introduce us to our topic. Your Excellency, you have the floor.
Thank you. Dear colleagues, thank you for being with us this afternoon, and I want just to really thank all of you, because I know that there is a lot of programs during these weeks, but you accept to manage your time and participate to this side event. Dear colleagues, since the World Summit for Social Development in 1995, this Commission has been responsible for implementing the objectives for social development described in the Copenhagen Declaration and developed more fully in the SDGs. Health is a core principle of both of these UN statements. Member states must seek to promote health and well-being for all ages, and this includes mental and reproductive health. These social development goals commit us to the highest attainable standards of physical and mental health. They require that we eliminate sources of instability for families, and they insist that we give people of all ages with the values they need to fully develop their health and dignity. The Declaration of Human Rights states that the family is the natural and fundamental group unity, and it is entitled to protection by the states. In Burundi, the traditional family remains at the heart of our community life and cultural values, and the extended family plays a significant role in social cohesion. For Burundi, the family is a key actor in sustainable development, a space of intergenerational solidarity, and a place where children enjoy safety and cultivate fundamental values. Subjecting children to medical treatments that permanently alter their reproductive threatens their present and future family stability and compromises their health and dignity. This is especially true if the treatments have not been rigorously tested and do not demonstrate long-term mental and physical health benefits. As the Convention on the Rights of Child reminds us, the best interests of the child must be our primary consideration, and those institutions that are supposed to care and protect them must conform with the highest standards for health as established by competent authorities. I now look forward to hearing what our panel of experts has to say on this subject. I thank you.
Thank you, Ambassador Menor-Tanga, for reminding us of the UN standards for health and the protection of youth and the critical role of the family. Thank you. Next, we'll hear from Miriam Grossman, MD. Dr. Grossman is board certified in child, adolescent, and adult psychiatry. Her current practice focuses on youth who have distress about their sex, as well as on the parents of those youth. Dr. Grossman is a senior fellow at donoharmmedicine.org and the author of 5 books, including You're Teaching My Child What and Lost in Transnation. Her books expose the origin and hazards of the sexuality and gender industry, and they have been translated into 11 languages. She has testified in Congress and lectured at the British House of Lords and at the United Nations. She is featured in the Daily Wire's What is a Woman, Fox Nation's The Miseducation of America, and many other documentaries and popular podcasts. Her expert psychiatric opinion is sought for witness testimony and court reports, and you may visit her at miriamgrossmanmd.com. Dr. Grossman, you have the floor.
Thank you so much, Josephine. Thank you, Ambassador, and thank you to everyone at Concepts of Truth International. Also, thank you to Do No Harm, donoharmmedicine.org, which is a group that is devoted to removing identity politics from medicine. And Do No Harm has graciously made available to all of you copies of my book, Lost in Transnation, and there's a pile of them over there, so as you go out, please help yourself to my book. I am here to explain why you must reject gender-affirming care that's aggressively promoted to your countries by UN agencies such as the Office of High Commission of Human Rights. But first, I want to tell you how I got to be sitting here today. Years ago, I went to NYU Medical School, and it's just down the street from here on 1st Avenue and 30th Street. It was there that I learned about the wonders of female biology. And by that, I mean the monthly cycle, the creation of life, and the science of maternal-child bonding, both before and after birth. To me, those phenomena were fascinating and miraculous. In 1983, my rabbi told me to write a book for girls about the science of their maturing bodies and instill in them a sense of wonder for the way that they are made. And here is the book, The Wonder of Becoming You. It became a classic, and it's still in print 38 years later. It was translated into 4 languages, including an adaptation for Caribbean girls. I continued on my mission to educate girls and women with 2 other books. I wrote Unprotected in 2007 while working as a psychiatrist at the Student Counseling Center of UCLA. That book is about the high cost paid by young women on college campuses who have been led to believe they're just like men. In 2009, I wrote the book, You're Teaching My Child What? which warned parents about the dangers of sexuality education, such as the programs promoted by UN agencies. Those programs don't promote sexual health. They promote sexual freedom. And that places youth, especially young women, at risk for unwanted pregnancy, emotional distress, and incurable infections. In that book, I warned parents about gender ideology. This was in 2009. I wrote, "Genderland is a dumbfounding departure from reality and a recipe for physical and emotional disaster for our kids." And I was referring there to the fact that sexuality education programs, such as those promoted by the United Nations, tell young people that you can be something other than your biology, that you can reject your bodies. So the theme running through all of my work for 40 years is biology matters, and that female biology in particular is unique and miraculous. Today, those facts are more valid and necessary than ever. And that is what led me to sit here today, because the ideology that gave rise to gender-affirming care denies biology, and it erases women. And here are a few biological facts that the United Nations does not want you to know. And there's a lot more than this. I mean, you'll see in my book, there's 300 pages of biological facts, but I only have a few minutes with you, so here's what I want to say. Sex is not assigned at birth. Sex is established at conception. The moment the egg and sperm unite, you have either a male or female, only two possibilities. And the difference between male and female are seen within a few days of fertilization. Okay, when the fertilized egg is still in the fallopian tube and hasn't yet implanted in the uterus, we already have seen differences between male and female. Before the new life is even visible to the human eye. It's deeply troubling that the United Nations pressures you in the developing world to teach that sex is assigned at birth, as if it's a random decision that might very well be incorrect. Students are told that their identities are separate, completely independent from the physical reality of their bodies. In other words, students are told that disembodiment is healthy and normal. They're led to believe that if a boy feels like a girl, whatever that means, I don't know what it feels like to be a girl, then he is a girl. Those ideas have no basis whatsoever in science or medicine. This way of thinking obliterates the meaning of the words girl and women. Because if a boy can be a girl and a man can be a woman, then girl and woman mean nothing. I'm on a mission. I'm on a private jihad against these falsehoods. And I also want to point out that it is preposterous that the United Nations has, and it will start in a few weeks, a commission on the status of women, when according to their definition, women include men. Gender-affirming care is based on the premise that the beliefs of all patients, regardless of age, should be rubber-stamped by clinicians and medical interventions. And medical interventions, including the removal of healthy organs, must be available on demand. The evidence against gender-affirming care is formidable and growing by the day. And if you're following the news here in the United States, you'll know that I'm not exaggerating when I say there are developments nearly every day. And all those developments are against this gender-affirming care policy. Even the World Health Organization admits The evidence base for children and adolescents is limited and variable regarding the longer-term outcomes of gender-affirming care. I'm going to focus on the dangers of gender-affirming care, and especially the dangers to girls, because of the skyrocketing numbers of youth in the Western world who mostly are girls. Gender-affirming care suggests that if a girl is seriously uncomfortable with her developing body, she should be provided with a binder, an elastic undergarment that will flatten her breasts, making her appear more masculine. You and I know that many girls feel self-conscious or worse with breast development and menstruation. We need to normalize those feelings and provide reassurance. But gender-affirming care suggests to such girls that they may be boys. They're uncomfortable with their bodies because indeed they were born in the wrong body. Now, as you might expect, smashing your breasts for 8 to 10 hours a day has consequences. One study of nearly 1,300 girls found that almost 90% experienced back pain, overheating, chest pain, or shortness of breath after wearing a binder for the whole day. Nearly 40% experienced severe pain. In my book, I describe a young woman who explained that 2 to 3 years of binding her breasts made them look strange and misshapen. She realized that even if she wanted to return to living as a girl, they would never look the same. And so she decided at age 15 that there really wasn't any point in keeping her breasts, and she had them removed, a choice she soon regretted. You want to save the girls in your countries from this nightmare. Do not permit binders to be sold. They are dangerous and can have permanent consequences. The next step in gender-affirming care is blocking puberty. Parents are told that puberty-blocking agents are safe and reversible. Doctors and therapists claim it's like pressing a pause button when you're listening to music or watching a video. A pause button, they say. Well, it turns out that puberty blockers are so safe and so reversible that they've essentially been banned in Norway, Sweden, Finland, and England, with serious concerns also raised by medical authorities in France, Holland, Denmark, New Zealand, and Australia. Those countries have looked at the evidence and concluded that blocking puberty has no long-term benefit, while there is evidence of harm. Puberty is not a disease. Puberty is necessary to mature psychologically, emotionally, and cognitively. Puberty is necessary for normal sexual response and fertility. Suppression of puberty in a healthy child is a risky experiment. Too many of my medical colleagues have forgotten that the body has its own wisdom. Puberty is a natural organic process, not a disorder. We cannot assume, as gender-affirming care does, that it can be turned on and off synthetically without paying a price. In fact, for the vast majority of children who are distressed about their sex from an early age, puberty brings relief because hormone surges propel the development of their brains, and they come to terms with the permanent reality of their sex. How am I for time? I'm okay? Thank you. How does interrupting puberty affect the development of a child's brain? We have no idea. As 3 physicians wrote in a letter to a journal called Archives of Disease in Children, quote, blockers are now being used in the context of profound scientific ignorance. Profound scientific ignorance. Is that really what you want for your children? Is that what you want in your country for young people? Of course you don't. We do know the following, that during puberty, bones normally become stronger. Their density increases. Puberty blockers prevent the increase in bone density. Teens develop osteoporosis, brittle bones that are easily fractured, a condition typically seen in older women. And that is part of the story of why there was a national outcry in Sweden where a young girl who had been placed on puberty blockers after a few years developed fractures of the bones in her spine. The hospital issued an apology to the family, admitting that they hadn't been properly told of the side effects and that the scientific basis for blockers in children is weak. The girl's mother said, "We were guinea pigs." Consider also that blockers potentially trap kids in a permanent gender identity crisis. Remember, many studies show that a large majority of kids grow out of their gender confusion if they are allowed to go through normal puberty. Therefore, so-called medical affirmation or gender-affirming care may cause persistence of the false identity, of the identity confusion, when otherwise it may have resolved on its own. I'll just talk to you for a minute about testosterone. Giving girls testosterone is dangerous and experimental. A girl's testosterone level should not be over 45 nanograms, but if she is a victim of gender-affirming care, her level may reach from 800 to 1,000. Okay, so normal, again, normal is 45. Gender-affirming care calls for levels of up to 1,000. A boy's estrogen should be under 40. With gender-affirming care, it can reach 200. Now, the brains of these young people are exposed to these abnormal levels during the most critical time of growth and restructuring of their brains since the womb. Where are the studies on the impact of this on kids' brains? There are none. This is what happens to girls on testosterone from 1 to 6 months of treatment. A deepening, permanent deepening of her voice. Cessation of menses, acne, clitoral enlargement, permanent clitoral enlargement. Vaginal atrophy, that's what happens to menopausal women. Mood lability. Those are just some of many side effects of putting a girl on testosterone. After 6 months, you're going to see facial hair and loss of scalp hair, and those are also permanent. A girl's body is not designed to be exposed to super high levels of testosterone. These are some of the medical risks that she faces. High blood pressure, high cholesterol, type 2 diabetes, erythrocytosis, pelvic pain, and uterine cancer. This is a partial list. Now let's talk for just one moment about WPATH, which is the World Professional Association for Transgender Health, which sounds impressive. They present themselves as a global authority on transgender health, and their so-called standards of care are presented as the gold standard, the only valid option. But we had something a few years ago called the leaked WPATH files, and you can find this everywhere online. And what we saw there was WPATH professionals, doctors, openly discussing the lack of scientific evidence for what they do to their patients. WPATH is run by activists whose goal is affirmation at all costs. When you see WPATH being referred to by UN agencies or by other groups that have an impact on the policies in your countries, that should be a red flag. Please understand what WPATH is. It's an activist organization. These are some of the young people who went through gender-affirming care and are now speaking up against it and bringing lawsuits against their doctors. This is Daisy. Daisy is a woman who was on testosterone for 5 years and had her breasts surgically removed. She then regretted what she had done. She decided that she wanted to live as a woman once again. She realized that she would never be a man and that the whole thing was based on falsehood. She got married and she had 2 children. This is her second child. She posted this picture of herself on X with her newborn just minutes after giving birth. Look at her face. She explained in her post that while she was joyous at the birth of her daughter, she was grieving her lost breasts. At this moment, she fully comprehended her loss and the loss to her baby, and she wanted the world to know. Daisy is a victim. There are many, many thousands like her all over the Western world. Please protect your girls from traveling down the same path. Thank you for listening.
Thank you, Dr. Grossman, for that brave report and for getting the word out year after year and helping many, many people. After hearing Dr. Grossman's talk, you might be asking yourself, how is it that these practices have continued for so long right under the noses of medical organizations? And if the harms are truly so significant. And I know she touched on this, and here to give us a more in-depth discussion about that is Joseph Figliola. Mr. Figliola is a policy analyst at the Manhattan Institute, where he researches and writes about the scientific, cultural, and philosophical dimensions of pediatric gender medicine. His work frequently appears in City Journal and other publications, including The Dispatch and New York Post. He graduated summa cum laude from the State University of New York at Geneseo and also earned a master's degree from NYU Center for Experimental Humanities. Mr. Figliola, you have the floor.
Thank you. Thank you so much. Thank you, Josephine. Thank you, His Excellency. And thank you to Concepts of Truth for having me. I really appreciate it. Sorry. So the context for my talk is really to help everyone here kind of understand how we could be in a position where, according to the highest quality evidence from systematic reviews that consistently find that there's only low quality evidence of benefits for gender affirming care, that virtually until very recently, almost the entire US medical establishment, all the medical associations pretty much unanimously endorse affirming care. So kind of give you more of an institutional walkthrough. So the problem is, despite medical practice reversals abroad and the findings of systematic reviews, the highest quality of evidence in evidence-based medicine, virtually every US medical association has endorsed so-called gender-affirming care for minors. A quick note here, a medical practice reversal is when the sort of the standard treatment for a particular condition is reversed in light of a new treatment based on the latest evidence. And evidence-based medicine is sort of an aspirational, it's a field that aspires basically to make recommendations for healthcare that are based on the highest quality evidence, limited harms, while also considering what's known as patients' values and preferences. I'm going to talk more about patients' values and preferences later on, because that often comes into the debate about whether or not this care should be made accessible to minors. A quick note, I just want to talk about a little bit about the history of gender medicine and what the original clinical rationale was. And so the original clinical rationale for intervening medically on children was actually because of a lack of poor outcomes among adult transitioners. And so in the Netherlands in the 2000s, a treatment protocol was developed called the Dutch Protocol, which was basically the pioneering protocol to sort of to medicalize minors via surgeries, puberty blockers, hormones. This was what you would recognize as a very small sample. It was about 72 youth overall, and interestingly, the study has never been duplicated despite attempts in the United Kingdom to duplicate the success of the Dutch protocol. The study, by the standards of evidence-based medicine, has a number of limitations. For one, the sample is really small. There's lots of issues with the actual measures that were used, particularly the gender dysphoria scale. There's very high loss to follow-up, which is when participants that enroll in the study originally drop out, so we don't have data on their outcomes. And then, of course, one of the most important really issues here is there's confounds in the study. So what this means is there are things that we can't control for. In the Dutch protocol, these children were offered psychiatric medication and psychotherapy. And so the problem here is that we can't determine whether or not any improvements that are documented are a product of the hormonal interventions, or is it due to these confounding variables. It's important to note that in evidence-based medicine, a study like this would be very low in the evidence hierarchy precisely because it doesn't have a lot of causal power in determining whether or not this study actually means anything. And another note about the Dutch protocol was that it was originally developed for a very specific clinical population. So this is basically childhood onset dysphoria cases that happen very early. Children had to have no psychiatric comorbidities, and they also had to have approving parents. And what's really interesting is that, and Miriam got into this a little bit in her presentation, is that basically around the Western world, starting in the late 2000s, early 2010s, there's a dramatic reshaping of the clinical population. There's essentially a brand new clinical cohort. And so instead of seeing frequently natal males, you would say, showing up at gender clinics, you're seeing adolescent females, and you're seeing adolescent females with often frequent psychiatric comorbidity, and in some cases also neurodevelopmental issues. And so one thing to note here from the jump is that the clinical population that this protocol was designed to treat, the modern population is extremely different, but we typically treat the newer patient cohort as if it's the same as the original cohort. Although by the standards of the Dutch protocol, virtually no one in the United States that currently seeks this treatment would have been eligible for care. European practice reversals. So many people may not realize that the United States is sort of increasingly becoming out of step with a number of other countries on how they conceptualize treatment for gender dysphoria. So in the United Kingdom, after a number of systematic reviews, first two reviews were done by NICE, which is a governmental entity in the UK, and then later there was a CAS report, which was done by England's National Health Service and by Dr. Hilary Cass, which took multiple years. At the time, it was the most comprehensive report on treatments for gender dysphoria. In addition, Sweden and Finland, Sweden's National Board of Health and Welfare, Finland, COHERE, health bodies within these countries formally actually looked at the evidence base and determined that the evidence for benefits was weak and there's significant evidence for harms. That plus changes in the clinical population made it so that the standard treatment approach is now a lot more conservative, and generally speaking, it's psychotherapy is the standard treatment. And the reason for this is pretty simple. It's because psychotherapy has a much favorable risk-benefit ratio, as you can imagine, than hormonal or endocrinological interventions. So puberty blockers, generally speaking, are not allowed in these countries. The UK is currently fighting about whether or not to engage in a puberty blocker trial. Cross-sex hormones are only prescribed in exceptional circumstances, and generally they would not be prescribed to any youth that are that fit more of this, what you would call ROGD, rapid onset gender dysphoria population. If anything, they would look for youth that conform more with the original Dutch model. the legal landscape in the United States. So in contrast to European countries and the ones I just named where they have centralized healthcare, the United States is a hodgepodge of separate policies. So roughly 27 states in the United States have formally prohibited access to these treatments in some capacity or another. About 17 states have passed what you would call sanctuary laws for gender-affirming care. And so this is when states make gender-affirming care a legally protected healthcare activity. And a number of states also have passed conversion therapy laws, which used to only apply to sexual orientation, but many of them now have been modified and extrapolated to gender identity, which means the default approach is that you have to affirm a child or else you're potentially running afoul of these conversion therapy laws. In addition, the different administrations have tried to influence policy. The Biden administration previously did. The Trump administration has passed a number of executive orders to try to curtail access to these procedures. They're also in the process of implementing a number of federal rules that still have to go through the rulemaking process, but if they succeeded, they would basically prevent CHIP and Medicaid from reimbursing gender-affirming care, and they would prevent healthcare entities that receive federal funds from also rendering these practices. I want to talk about the HHS report. So for some of you that may not realize this, but in May of 2025 and then in November of 2025, there was an initial report on best practices for treating gender dysphoria by the Department of Health and Human Services. At the time it came out, it surpassed the CAS review as probably the single most comprehensive document on the evidence base for gender-affirming care. So it actually was an umbrella review, which means it looked at an overview of systematic reviews. In this case, it included 17 systematic reviews in total. And it also did a novel ethical analysis and sort of made clear a number of the kind of risk-benefit calculus that a lot of people normally overlook. I think this peer reviewer gets to the heart of the kind of issue here, which is that when the risk-benefit ratio for a particular treatment is unfavorable, when there's low-quality evidence for benefits and there's considerable evidence for harms, which in the case of affirming care, as Miriam noted too, the harms for girls, but there are harms for boys as well, cognitive harms, cardiovascular, metabolic, cancer, elevated cancer risks, bone health, brain functioning, and then of course all the harms that we really just aren't aware of because there hasn't been enough longitudinal data on these issues. Basically, if you find yourself with a treatment with this risk-benefit ratio, there's no right to access this treatment and there's no right to recommend this treatment. So the logic is basically, according to medical ethics, there would have to be evidence of benefits and low certainty for harms, but in this case, the clinical benefit ratio is pretty clear that this is an unfavorable practice. And so really cutting through the heart of it, regardless of what you might think about all the framing of gender-affirming care, really what it gets down to is there good evidence for these treatments? In this case, there is not, and there's, as I mentioned, at least considerable evidence for harms. One more note too, that the HHS report was peer-reviewed, including by evidence medicine experts from Belgium, and they actually sought peer reviews from many of the American medical associations that are frequently critical of, that frequently endorse gender-affirming care. So the American Endocrine Society and the American Academy of Pediatrics as well. And this is really key here. The medical association response initially until several days ago has generally been projection and refusal to take accountability for how their position statements embracing affirming care diverge from the findings of systematic reviews. So for example, the American Academy of Pediatrics issued a press release after the HHS report came out where they said the report relies on a, quote, narrow set of data and perspectives and misrepresents the current medical consensus and fails to reflect the realities of pediatric care. So a number of things to unpack here. For one, it's fascinating to me because the American Academy of Pediatrics position statement on gender-affirming care is not based on any systematic reviews at all, and it was written, drafted, and conceptualized by a single junior pediatrician, Dr. Jason Rafferty. And of course, there's a mistake here, which is that medical consensus and consensus-based medicine is not evidence-based medicine. Just because a number of medical associations agree that there's a consensus doesn't tell us anything about whether or not the practices hold up under scrutiny. So how do we get here? I like this phrase a lot, the broken chain of trust. My colleague, Lior Sapir at the Manhattan Institute often uses this. And there's an assumption that medical associations act in the public interest and, generally speaking, would only recommend treatments or practices that are known to be evidence-based. And in practice, these are not really official arbiters of medical standards. Medical associations are really first and foremost trade associations that represent their members' interests. And the more I study gender-affirming care and medical associations and how they kind of arrived at policy on this area, I increasingly note there's a lot of category confusion. And so a lot of medical associations frame access to gender-affirming care very much as a civil rights problem, where it's framed as, on its face, discrimination to deny access to these treatments to a trans-identified minor. And what's interesting is that the Supreme Court, which heard a case involving Tennessee's ban on gender medicine, they determined in that case that they upheld Tennessee's law, and they acknowledged that the law as written doesn't discriminate against transgender status or sex. It draws distinctions based on clinical rationale, which is that these treatments do not work, and it's in the state's right to not allow a practice that they believe does not have strong evidentiary support. And so I think that the civil rights framing, I think, short circuits a lot of people's understanding of this issue, where they automatically assume that anyone who is skeptical of affirming care must be skeptical, just is inherently bigoted or is discriminatory. And so there's been this related move where there's two different framings of kind of ways to think about gender dysphoria. There's the gender dysphoria framing, which exists in a medical paradigm where it's I would still think a disorder in the sense that distress is a key feature, and that's what we're trying to do is resolve this distress, and then we can figure out if these treatments actually do that. And then there's this gender incongruence paradigm, which is actually pushed by the World Professional Association for Transgender Health, which removes distress as a key feature and basically argues that this treatment should be made accessible solely based on an identity claim, solely based on having a, quote, identity that's different than whatever your sex assigned at birth is. And I reject the framing sex assigned at birth, but that's a separate issue. And so I think a lot of these medical associations arrived at their positions on this issue, I think, thinking about this as predominantly a civil rights problem. And this often happens via institutional capture and more specifically by committee capture. So committee capture is when a smaller insular part of a larger organization is sort of empowered to shape policy in a particular area. And in a lot of these medical associations, what happens is often a LGBTQ affiliation group or membership group that often has intellectual or financial conflicts of interest towards preserving this paradigm are the sort of the architects of these policies. And I did a long report on the Texas Medical Association a number of months ago that basically documented over a number of years how the association came to adopt policies along with through committee capture. So the key players in the United States and how the illusion of consensus was created, there really are not that many major associations that shaped the idea that gender-affirming care is safe and effective. The major players are the World Professional Association for Transgender Health, the U.S. Endocrine Society, and the American Academy of Pediatrics. And as Miriam mentioned, it came out through litigation, actually, through a case in Alabama, Boe v. Marshall, that WPATH had actually commissioned and then suppressed systematic reviews by researchers from Johns Hopkins who, like the findings of all these other systematic reviews, only found low certainty evidence for benefits. However, because those reviews didn't dovetail with WPATH's desire to expand access to this treatment, they suppressed the reviews and basically prevented the Johns Hopkins researchers from independently releasing them. The U.S. Endocrine Society similarly has endorsed gender-affirming care, but interestingly, they also did not base their position statement off of the findings of systematic reviews for minors. They based it off systematic reviews for adults. And so in the parlance of evidence-based medicine, this is called a discordant recommendation, which is when the evidence for the actual recommendation don't overlap. And then, as I mentioned, the American Academy of Pediatrics is another organization that is, I think, has played a major role in convincing the general public that this is safe and effective practices. As I mentioned, their position statement was written by a single pediatrician, Dr. Jason Rafferty. And interestingly, the World Professional Association, the WPATH guidelines and the Endocrine Society guidelines have overlap in people who wrote for them, and they often engage in what's known as circular citations. So they both cited each other as authorities, which then sort of artificially inflated the degree to which this was an accepted practice. And then a number of medical associations in the United States basically take their cues from these organizations, which is how you end up with virtually every U.S. medical association endorsing the practices despite not actually assessing the evidence themselves. One more point I just want to note here, and a lot of people may not realize this, but although the Trump administration has recently been engaging in a number of rulemaking and executive orders to shape affirming the treatment for pediatric gender dysphoria, the Biden administration actually engaged in quite a bit of advocacy for gender-affirming care. And so in May of 2021, the administration, very early on in Biden's term, the administration issued guidance of interpretation in light of Bostock. And what this did was it functionally redefined sex to include gender identity throughout the federal government. In March of 2022, the Office of Population Affairs released a memo entitled Gender Affirming Care in Young People, which also endorsed affirming care as standard practice. In April of 2024, the Biden administration issued a final rule. So the same mechanism that the Trump administration is currently using, these proposed federal rules. They issued a rule that actually modified Section 1557 of the Affordable Care Act to include non-discrimination protections for gender identity. So because sex protections under Section 1557 are imported from Title IX, and the Biden administration redefined sex to include gender identity, they were able to essentially create this rule that basically stated that if you didn't engage in affirming care, you could lose federal funds. So in a lot of ways, it's basically a reverse policy of what the Trump administration is currently doing. A quick note here, and this came out after Trump took office, and there was kind of some retrospectives on the Biden administration and overreach in this particular area. But a Biden aide actually conceded that our allies in the LGBTQ movement overstated the medical case for pediatric gender-affirming care, which I think highlights the degree to which a lot of people sort of take their cues from activist organizations in this space because they don't feel comfortable kind of weighing in on the area on their own. And so the future of pediatric gender medicine, what's next? And I just want to say a couple of quick things. I think as long as we have the ability to set states have the ability to set separate laws, there's always might be the possibility where affirming care persists in some capacity. However, I think it's really interesting that the sort of the medical associations have slowly started to flip, and actually a few days ago, the American Society of Plastic Surgeons formally broke with the medical consensus and actually released a position statement coming out against surgical interventions for minors, recognizing that the evidence base is not strong enough and that there's considerable evidence for harms, and that's their new official position. And what's also interesting is that same position statement also acknowledged that the evidence is virtually identical for hormones and puberty blockers. However, their statement didn't actually formally recommend not recommending those treatments. After that, interestingly, a number of publications, National Review and the New York Times, spoke to the American Medical Association, who up until this point has been a huge advocate of all of these practices. And when asked about the new position by the American Society of Plastic Surgeons, they actually agreed with that statement. And so I think it's really interesting here that what I think could happen is, just like only a few organizations were required to create a consensus around affirming care. All it requires is a few organizations to flip, and I think then it creates the permission structure for other organizations to follow suit. And for those who haven't followed the news, last week, in the first civil suit, a detransitioner in New York State was awarded $2 million in damages after suing their psychologist and surgeon. This person had a woman underwent a double mastectomy as a 16-year-old with multiple psychiatric comorbidities. They were not properly assessed. They were not properly informed about the risk-benefit profile of surgery. And I think this also has tremendous capacity to also shape the landscape going forward as insurers start to consider what this means for the practice. And so, thank you.
Thank you, Joseph. I think that's a side of the medical world that probably a lot of us have not been familiar with. And I think going forward, maybe we'll take medical recommendations with a little more of a critical eye. That was really interesting. So now for a deeply personal side of this issue to conclude our panel, we have, we'll hear from a detransitioner, Laura Perry Smaltz, who will be interviewed by Gary Ingram. Gary Ingram is the founder and executive director of Love and Truth Network, a ministry that equips pastors and Christian leaders to restore relational and sexual wholeness and biblical identity. Gary once lived in the LGBTQ world and talks personally about how God is transforming lives and setting captives free. He's been married to Melissa Ingram since 2007, and they have 2 boys. Laura Perry Smaltz is an author and speaker who shares her story of how she came to regret her transition and then reversed her treatment. She's appeared on radio, podcasts, and television, including in the documentaries In His Image and Trans Oklahoma. She also speaks and teaches on a variety of topics related to gender and sexual confusion at conferences, schools, and churches, and her story is available in her autobiography, Transgender to Transformed. She and her husband, Perry, direct Eden's Redemption, a ministry which aims to teach and equip people to understand gender and sexuality from a biblical perspective.
Hello to our friends at the United Nations. Laura Perry Smaltz and I am so grateful to be able to share her story of transition and detransition with you all. I wish that we could be there in person, but due to a family surgery I needed to attend to, that wasn't possible for me. But we're so grateful to be able to share in this pre-recorded video testimony with you. We begin this testimony by talking about how common it is for children to actually wrestle with a variety of things, moving from childhood into adulthood. And it is not uncommon for children to struggle with their gender identity. And that's where we begin this interview.
I've heard from so many people. I've seen many comments on YouTube videos and other places where people have said, I felt like the opposite sex at some point in my childhood. I wished I had been the opposite sex, or I felt like that. That is a very normal childhood experience at some point when we're wrestling with who we are and why am I a girl or why am I a boy, and I like these things or whatever. And I didn't really realize until I was much older, really after I detransitioned, I actually fit in really well with women. I am such a girl, and but it took, I think I had so much self-hatred that I was just really rejecting femininity.
Studies show, actually, if you just leave kids alone, now I think kids do need counseling, but if you don't have people piping in their ear all this stuff about trans ideology and all this kind of thing, that children, the vast majority of kids who experience gender dysphoria actually come to terms with their biology and become comfortable with their biology, even without intervention.
There's a forum that I was part of called, it was just called D-Trans on Reddit. And last time I looked, there was over 50,000 members. And of course, I'm sure there are some trolls on there, but it's supposed to be only people who have detransitioned or are thinking about detransitioning. And there are just hundreds and hundreds and hundreds of posts of kids saying, why didn't anybody stop me? Why didn't anybody tell me the truth? Like, why did somebody let me cut my breasts off? I was 14, and just heartbreaking stories. And so much of the time they said, I had trauma. I was dealing with this. I had been sexually assaulted or, whatever. And there's always something. But unfortunately, what's happening, because we're not getting these kids the counseling they need, we're giving them this Band-Aid solution that is going to make them feel better for a moment, but it's not fixing the reason they don't like themselves in the first place.
So the other thing, as you're sharing, Laura, also, I just so relate to a lot of what you're saying. When I was in my, probably just before puberty, in puberty, by the way, who loved going through puberty? I mean, as if every child on the planet, if you feel awkward during puberty, maybe you're trans. Well, it's so ridiculous. There's not a person on the planet who's loved going through puberty, maybe wanting to get to the other side of it, but going through it is always a challenge. But somewhere before then, so for a couple of years, 2 or 3 years, I really experienced some deep sense of gender dysphoria as well. I really experienced this longing that just made sense to me. I was with the girls all the time. I got along with them all the time. I wanted to spend time with them. I wanted to spend time with boys, but I was afraid of boys. I experienced sexual abuse at the age of 5 or 6 and early sexualization and all of that kind of thing. And I was also the opposite of you in terms of sports and all that. I was the one chosen last for the team, never in the first 3 quarters, that's for sure. But I just began to feel like this doesn't make any sense, God. You had to have screwed up big time. I should have been a girl. That makes sense that I would have been. And of course, I never even heard the word transgender or anything back in that day. And so the fact that I didn't have all these competing voices and all these, teachers and counselors and popular media pushing me in this direction, there is zero doubt in my mind that if I had that stuff at 10, 11, 12 years old, there's zero doubt in my mind that I would have absolutely grabbed hold of that and felt like this makes sense. This is what I'm longing for. This is what I'm supposed to be. I can see how it's so compelling given my own history. And for a while, even cross-dressing, even there was a particular dress that I would put on. I would kind of wear it I did for a couple Halloween seasons. But even in between those couple Halloweens, I would put that dress on whenever I could when no one was around the house, which wasn't very often. But I would put that dress on and just pretend and believe that I was a girl. Again, it just made sense to me. So for me, you're a detransitioner. I would be considered as a desister. And
Right.
I think that that's more common many times. Like you said, it isn't uncommon for people to feel like I should have been the other gender. Not everyone feels that way, obviously. But when you have a society now that has people in positions of authority and power who are supposedly the experts telling us that this is perfectly normal, that you simply need to go through these surgical procedures, these hormonal treatments, whatever, and you can actually live out your best life. I mean, that's kind of how it's portrayed. It's very compelling for children and very confusing for children.
When these kids have been convinced that the reason that they're not happy, the reason they don't like themselves is because they were supposed to be transgender, and then they go down this road and they take hormones and they have surgeries, and then they realize at some point that there's no pot of gold at the end of the rainbow. There is no magic pill that is going to make them the opposite sex. And I remember there was always this elusive happiness. Well, maybe another year of hormones, maybe once my beard comes in, maybe once my voice is a lot lower, whatever it was at that time that I thought would make me happy. I remember when I got to, I was looking at the genital reassignment surgery, so-called, and I was horrified when I realized how bad these surgeries are, how artificial it is, that this was not ever going to make me a man. I remember even realizing that I would never father a child, and then that seemed obvious at that time that I should have known that, but it just never occurred to me. I just never thought it through. But it's just not real what they do to these kids, and it is horrific, and there's all kinds of complications. I've heard so many horror stories. They say that large percentages, I don't know if it's changed any now in recent studies, but when I looked it up back then, is that 40 to 60% would lose all sexual feeling permanently.
When you couple self-hatred, which I also experienced in very, very intense ways, with envy, that there's this longing to be someone else, this longing to seeing and envy may start off as admiration to begin with, and then admiration can quickly become envy. It can be quickly become sexualized, and we're trying to kind of be wanting to become this other person that we admire or what have you, and you couple that self-hatred with that envy and sexualization, and wow, it really becomes this powerful cocktail for feeling, again, like concrete facts when it's really all based in these intense emotional experiences that we're having within.
I've heard them tell kids, various people will say, if you think you might be trans, go ahead and get your breasts cut off. And if you change your mind later, you can just get them put back on.
The truth is, you're supposed to toe the line, and everyone knows that you're supposed to be euphoric about all of this. And for those that I've known who have decided or even began to question, have I chosen the right thing? Is this really what I'm supposed to be doing? Man, nobody gets kicked to the curb faster than somebody who began to pursue like a transgender identity. And as soon as you start to question that, or if you start to move away from that, all of a sudden, like all those friends and all those people that were celebrating you and supporting you, they weren't really celebrating you from what I see. They were celebrating what you were doing that reinforces what they were doing and they believed in. And so you're always supposed to say the positive thing about what you've done. But then when, like you're saying, everything else in their life, they say, oh, it's positive, positive, positive. But then everything else in their life is falling apart, or many things are falling apart. And it's like there's a complete disconnect.
When I was single, I wanted to have children one day. I hoped that I would have children, but it wasn't a huge deal. It was like, wish I could have had children. Oh, well. But when I got married, that desire was so intense. And I longed to have a child with my husband. And I just didn't understand the spiritual implication there of when you're married in covenant with God and with, one man and one woman in covenant with God. And that desire was so much more extreme than it ever had been before. Mm-hmm. And so I cried myself to sleep for many, many, many months. Every single night would just cry and cry. And that was extremely hard for me. And I was not prepared for that burden. I knew that when I had a hysterectomy that I wouldn't be able to have children. But again, I think, a teenager or even a young adult who's never been married, who has not had children, has no idea what that desire is like until that desire gets awakened. Even though everybody's saying how happy this makes them, it gives you those euphoric feelings because you're able to kind of reinvent yourself, and you don't have to deal with that broken person that you hated, that you didn't like, So you can kind of be whoever you want to be, but it didn't actually fix anything else in their life.
For parents or policymakers at the UN or the United States or other countries, what advice would you give on protecting children from rushed care and ensuring that they get full information on risks and harms, essentially truly informed consent?
First of all, no child should be able to consent to medical transition. We don't allow children under a certain age. And of course, the laws are going to vary by country. But here in the U.S., kids are not even allowed to drink under 21, alcohol under 21 years old. They're not allowed to get tattoos, I think, under 18. Kids can go to Planned Parenthood behind the parents' back and get hormone treatments without the parents' knowledge. Yeah. But just like in my case, I knew that I would not be able to have children in the future, but that wasn't really a big deal when I was single, and especially not as a teenager. Most teenage girls don't want to be pregnant at 16 years old. Yep. So that's not a big deal. They're saying, I don't really care about having kids. But they can't understand what that's like to give up. That's right. Before that desire is truly awakened. And so I think kids cannot consent to that. So I really advocate for no child medical transition. Studies have shown in the past that even social transition pushes a child toward medical transition. Yes. Studies back by Kenneth Zucker back in, I think it was the 80s, showed that around 90% of children if they were not socially affirmed, if they were not given a new identity and, allowed to dress as the opposite sex, if they were put in counseling and therapy, about 90% would desist or no longer say they were trans. Mm-hmm. But now if kids are being socially affirmed, if they're given a new identity, they're allowed to dress as the opposite sex, huge majorities are going on to medical transition. And those that get on puberty blockers, studies have shown 95 to 100%, depending on the study, have gone on to medical transition. And so it's the complete opposite. So I really advocate for therapy and getting kids the help that they need. And also helping kids understand that all of us have things we don't like about our bodies. All of us have things we don't like about ourselves, and helping kids see the needs of others rather than being so hyper-focused on self.
I carried so much brokenness forward until I had someone pastorally and counseling and different groups that I got involved in where I began to finally unpack the junk and the garbage that I've been dealing with since for as far back as I could remember. And so, again, I just want to underscore, studies show that children will actually, the vast majority, will desist from their feelings of gender dysphoria over time. But I think in order to really have the kind of health that you and I are talking about, that Jesus can lead us toward, that we do need people that we can open up to and talk to. And for those people also, which so many today, both non-believers and even so many that claim to be Christians, are toting and supporting an LGBTQ perspective and even raising the question with people that, well, maybe this is actually the issue that you're experiencing. Maybe you actually are trans. Maybe this is something that you should be exploring. And when you insert those ideas into people's minds when they're already dealing with a mental health issue and maybe a variety of sorts of issues, you're really doing a massive disservice to them.
When I was on testosterone, it over time, at first I felt great, but over time, my autoimmune stuff started getting worse, and I was having a lot of cognitive issues even back then, before I started having all the brain problems I have now, which I think at least is in part from working in a moldy building for several years. But I know I was having a lot of cognitive issues. And I remember even thinking, like, what's wrong with me? Like, I was not like this before. I'm amazed I didn't get fired from my job because I just was not thinking well. I was always forgetting things, and just over the years was having more and more trouble. But I also had, I have a lot of shoulder and chest pain from the chest surgery. Like, I'm very rounded here. And I had a doctor one time. He was a plastic surgeon, not the one that gave me the original surgery, but a different plastic surgeon, and said that it appeared, at least, that the plastic surgeon, to make it look more like a male chest, had actually cut part of the muscles there. And I have a lot of pain there. My chest hurts all the time. I mean, not intensely, but it just feels like phantom pains, kind of. We hear about people that have had limbs cut off and they talk about phantom pains. Right. Sometimes it feels like I still have breasts there, but they're not there. But it's just kind of an aching. We're giving these kids a false solution. This will never solve their problems. It will never make them happy. It will for a time. Anything new is exciting. Any new adventure in life makes us feel good. But ultimately, it's not going to bring any lasting solution, and it's not going to solve the deeper problems.
Well, that was a moving interview and brave of Laura to talk about these things. And I think these messages that they expressed, as well as our panel, are messages that kids and parents need to hear to have the confidence to resist these things. So that pretty much wraps up our panel. And don't forget to take a book that Dr. Grossman's generously providing to you all through Do No Harm for free. Those books are on the way out. But for right now, let's open it up to questions. If you all have questions for the panel, just raise your hands. And yes, Julia.
Thank you so much, Concepts of Truth, and for the wonderful speakers for your remarks. My name is Yulia Kazan, and I work for the Center for Family and Human Rights, and we track social policies here at the UN on life, family, and gender. And what is really unfortunate to see is that to take the stand that you're taking today is effectively to be labeled anti-rights, pushing back progress on human rights. And I would like to ask Dr. Grossman if you could talk a little bit more about the harms of social gender affirmation, because I think the UN, many UN agencies are promoting that. UNICEF does. We released a report showing the extent to which that idea that you automatically have to affirm a child's gender, even if that is disconnected for their sex, that is the way to go. So I would welcome your thoughts on this topic as well.
So the question is about, the question is about social affirmation, which refers to a young person having a new name, a new presentation, dress, haircut, etc., using new pronouns, and sometimes using the restrooms of the opposite sex, maybe on school trips or during the summer at camp, sleeping in the dormitory of the opposite sex. Well, I think that what this does is it places the child on the path toward harm in several ways. First of all, when children look to adults to represent reality, to define reality, to represent reality. And when we follow the advice given us by professionals who practice gender-affirming care and educators, doctors, therapists, you name it, and they say when a young person presents their request to have a new name and new pronouns and to be considered to be the opposite sex or some other variation, that kid knows best. That regardless of their age or their development or other emotional conditions that they may have, regardless of all that, they know best. They know who they are. And that adults should always go along with that and honor that and use the new name and use the new pronouns. So in other words, the child gets to create their own reality. That's what we do. When we socially transition a child, we are putting tremendous power into the hands of these kids who might be 4 years old and have autism or whatever, but let's say they don't even have any of these comorbid, let's say they're just 3 or 4 years old. And we're saying, you know what, you know better than we do. And you can create your own reality, and we're going to rubber stamp it. We're going to go with it. So that's crazy. And we don't do that in any other field of medicine. We don't do that in any other field of part of parenting, common sense parenting. Now, what you want to do when that happens is to sit down with your child and talk and say, you know, this is interesting. Tell me more. How did you make this decision? Where did you learn about this? Why is it so important to you? And you know what? If it's important to you, it's important to me. And I'm going to find out everything that I can on this subject, but I am not going to call you by a different name. Your name is very, very important. Your father and I spent many, many months deciding on what to call you. Your name has meaning. Maybe we can come up with a nickname if you really insist that you don't want to use the name that we gave you. But we're going to continue having conversations about this. But what you have to do is remain anchored in reality. And I tell parents who aren't sure what to do to consider the possibility that in a few years, their child may come back to them and say, why did you do this? Why did you go along with it? You, in accepting this new identity that I chose, you effectively put me on an assembly line. And I wish you would have been the adult who was holding on to the truth and the reality of who I am and who I will always be. I think that's my answer.
One more question, and then I think we need to wrap up. Yes.
This is thank you very much, both of you, for waking us up to what's going on out there professionally. WHO, I mean, they have put out some pretty controversial things over the years. Did we do the right thing, or should we have stayed and used a more forceful voice, to counter some of their extreme positions?
Oh, that's a great question. Should we have pulled out, or should we have just had a stronger voice to oppose their positions? Well, you probably know better than I, because I haven't followed it that closely, but did we at any point have that stronger voice at the WHO? I don't know. I would have loved to have seen a stronger voice, because you're right, the WHO has come out with outrageous policy in the past. So I think my preference would have been a very strong voice, but if that's impossible, then I guess pulling out is the answer.
We're out of time. I'm sorry, but we can maybe have a couple more questions in the hallway, but I believe the next group would like to get in. So thank you to the panel. This was very edifying.